Good evening. Hi. On behalf of the Center for Health and Biosciences, I want to welcome you to the Baker Institute. My name is Keonta Moore, and I'm a fellow in child health policy here at the Baker Institute. As you may have noticed as you walked up our stairs into the building, an inscription on the side of our building that says, "To build a bridge between the world of ideas and the world of action." This sentiment drives our work here at the Baker Institute, and the Institute has historically facilitated conversations around the most challenging issues of our time, hosting leaders such as Nelson Mandela and promoting the freedom of ideas along with real, actionable solutions. We are delighted to be co-hosting this event today with MD Anderson. Health disparities is a central part of my work. And it's not often that I have an opportunity to engage in a dialogue with someone who understands the intricacies of law and medicine the way that Dr. Matthews does. So with that, I'd like to introduce Dr. Elizabeth Travis, who is Associate Vice President for Women and Minority Faculty Inclusion, and Maddie Allen Fair Professor in Cancer Research at the University of Texas MD Anderson Cancer Center. Dr. Travis will introduce our speaker. Thank you.
Thank you very much. So you already know who I am, and thank you for doing that. We are so pleased to be co-sponsoring this lecture with the Baker Institute for Public Policy, and we thank you for your hospitality. I would particularly like to thank a colleague. We've worked together on a number of things. Vivian Ho, Director of the Institute Center for Health and Biosciences. I picked up the phone after I heard Dr. Matthew speak at a AAMC meeting a few years ago. I called Vivian. I said, "Do you think we could do something with the Baker Institute around this?" And she said, "Why not?" And here we are. So thank you, Vivian. Co-hosting this event reflects the commonality of our shared commitment to make the Texas Medical Center a magnet for those who choose to work, train, and receive care in an environment of cultural sensitivity, equity, and inclusion. It also speaks to our responsibility to shed light on the public policies and legal impediments that impact healthcare in our greater Houston community, and I might add, one of the most diverse cities in the country, as you all know. Our speaker today, Professor Dayna Bowen Matthew, is the William L. Matheson and Robert M. Morgenthau Distinguished Professor of Law and the F. Palmer Weber Research Professor of Civil Liberties and Human Rights at the University of Virginia School of Law. She holds an appointment in the School of Medicine's Department of Public Health Sciences. Before joining UVA, Professor Matthew was Professor of Law and Vice Dean at the University of Colorado School of Law. While in Colorado, she first of all got her PhD, and she also co-founded the Colorado Health Equity Project, a medical legal partnership incubator that has documented the effectiveness of merging the work of healthcare providers and lawyers to improve health outcomes, particularly for vulnerable population. This has become the focus of her research, which continues in Virginia. Dr. Matthew received her bachelor's degree in economics from Harvard Radcliffe College, her law degree from the University of Virginia School of Law. She has been a law clerk in the Supreme Court of Virginia, Robert Wood Johnson Health Policy Fellow, and Senior Advisor to the Director, Office of Civil Rights at the Environmental Protection Agency. While the University of Virginia is her academic home base, she currently is involved in a number of national organizations. She is a non-resident senior scholar at the Brookings Institute, a visiting fellow with the Congressional Black Caucus, and a board member of the Team Heart Rwanda. Tackling tough issues is not new to Professor Matthew, starting with her win at the moot court competition while in law school. Her articles and book chapters focus on race inequities in mental health, healthcare, and housing. Professor Matthew has developed an innovative model of preventive lawyering juxtaposed with healthcare that is illustrated and expanded in her book, Just Medicine: A Cure for Racial Inequality in American Healthcare. Please join me in welcoming Dr. Professor Matthew to the podium. Thank you. That's the best introduction.
So I'm going to start here, and if my laugh lets me, I'm going to wander, because that's what lawyers do. So I'm going to test it out a little bit over here. Yeah, it looks like I can do that. I want to say thank you, because this day has been an educational one for me. It has been an inspirational one for me. What you're doing here in Houston is touching so many issues in ways that I travel a lot around the country, I don't think is happening anywhere else. I'm amazed at the synergies, both in the independent institutions at the Baker Institute and over at MD Anderson, and then to bring those synergies together, research, clinical, and community study, it's very impressive. I'm also especially grateful to you, Liz, for finding me and for finding so many other women and minority leaders and giving that talent a place to flourish. I'm very grateful to you also, Dr. Ho, for saying yes to this person you don't know anything about, who's a lawyer nonetheless, and I'm not going to squander this opportunity. So if you can still hear me, I want to speak today in 4 chapters. I have a lot of slides, because I have the sense that there are 2 different kinds of information I'd like to share with you. I'm going to go pretty fast. I'm from New York City, and so put your roller skates on. In order to get through all these slides, I'm going to go pretty fast. And what I'd like to do is leave some time for discussion, because as I said, I've learned a lot today, and I'm going to continue hopefully learning from you. I'm wondering, is there a monitor that I can see what's going on here? Okay. All right, so I don't have to turn around. So 4 chapters. I want to talk about what just medicine is and is not. So I'll start chapter 1. Why should we have something called just medicine? Why should justice be associated in any way with medicine at all? That's going to be chapter 1 of my discussion. Then secondly, I'm going to talk about what is this thing called just medicine. Once we have a why, what does it look like? There is unjust medicine. And I'd like to talk about where it operates nationally. I won't touch on it globally, but globally for sure, because I want to spend a little bit of time talking about the data here in Houston and talk about the injustice of medicine here right in our backyard. And then lastly, I hope I give you some ideas about what to do about it. After I've identified the problem, which we do an awful lot, I hope that there'll be something. So I'll talk about those in terms of 4 chapters and what I want to talk about. Okay, so chapter 1, why just medicines? This is my moving truck. This was what it looked like for me on August the 11th of 2017. Now, unless you're living under a rock, you realize going to Charlottesville on August the 11th in 2017 was a fraught proposition. That was my moving day, and I'd left a perfectly good job, as my husband will tell you, in Colorado, to go to the University of Virginia and begin teaching law there on August 11th. My moving truck driver said, "We're not going." Now, as you heard in the introduction, I'm a race scholar. So there's a race riot in Charlottesville. I want to be there. I want to see this and experience it firsthand, and my husband was like, no, that's not going to happen. So August 13th, I made it finally down to the University of Virginia, and what I thought I was going to find was this bucolic setting, right? This is what I was going to University of Virginia for. That's the law school. It's amid the Blue Ridge Mountains. That's what I was going to see. However, that was my welcome committee. That is not a photograph from 1954 or 5 or 6 or 7. This welcome committee was my advanced team in the University of Virginia, and the guy who spells B-I-B-I-E-L tells me that Jews are not in the Bible, right? And there he is saying, "Welcome to Charlottesville." Now, here's the thing that was really scary. By August 11th, that was my welcome committee. They looked just like my students. I don't know about you, but I'm not as afraid of the guy with the pointy hat as I am of these guys, because I can't tell what happened to them to make them think that running around Charlottesville yelling blood and soil was productive, that running around Charlottesville saying it's okay to be white and arming themselves was appropriate. This, for me, was a real jarring welcome to Charlottesville, Virginia. But it also gave me the sense that I was there for a reason. I teach constitutional law, and so I'm going to start with the 13th Amendment. Everybody knows what that is, right? The 13th Amendment, it did what? Emancipated slaves, right? So it abolished slavery. I think the answer came from right here. Do you know it wasn't the original 13th Amendment? No. No. So that's okay, because most of my law students don't know. So the 13th Amendment says that Congress cannot enforce slavery. The original 13th Amendment said the exact opposite. No joke. The original 13th Amendment was language that said, in an unamendable way, that Congress cannot require states that want to pass and enforce slave labor, couldn't undo that. And if that was just a bit of history, it wouldn't be all that important except for this. The original 13th Amendment actually passed with the requisite 2/3 vote in the House of Representatives. The original 13th Amendment actually passed with the requisite 2/3 vote in the Senate. And the original 13th Amendment was actually on its way to ratification. 6 states, including Virginia, were ratifying this, and they only needed 3/4 of the state. It could have been really different for me at this moment, right? If that, instead of the language that got passed, had been enacted. Why do I tell you this when I'm talking about this? The founder of my university, Thomas Jefferson, wrote the Declaration of Independence, and he said, all men are created equal. Think about that and juxtapose it to his only full-length published book, Notes on the State of Virginia. Has anybody ever seen this book? Notes on the State of Virginia has a large section dedicated to explaining why blacks are not human. What's different about blacks is that they don't emotionally experience love. What's different about blacks is that they are hard workers and they are ardent in their love for their females, but more like orangutans, according to Thomas Jefferson. Now, I'm not just bashing Thomas Jefferson in the 13th Amendment in the original language, but what I want to say to you is we have baked in our DNA a fundamental ambivalence about the humanity of blacks and race, and it persists through our medical system. That's my thesis. And I said I wasn't going to squander this opportunity, so I'm going to say all the controversial stuff and then ask you to engage with me if you think it's not true. So there is what we call a race problem in medicine because there's a race problem in the United States of America. And I put the picture of Frederick Douglass up because I recommend to you highly the wonderful speech that he made called The Race Problem. And I want to let the word hang in the room a little bit because it's not comfortable, it's not easily spoken of, but I want to take some of the sting out of it and have a conversation for the rest of my 40 minutes with you about the race problem in healthcare. So what does it look like? How does it manifest? I'm going to give you 2 exemplary pieces of data because quite frankly, I could spend the rest of the day giving you the data that I'm sure many of you are already familiar with, but I want to argue that health disparities, that is the 84,000 people that die of unjust and avoidable disparities in the United States annually, are not simple, but they are in part due to this ambivalence that we have about race and humanity where minorities are concerned in the United States. So let's use infant mortality as the first example. We know generally that on average 2.5 times more likely a black woman will lose her child in the first year of life than a white woman will in the United States of America. And that's on average. Because as soon as I got to Charlottesville, I started looking at the data in Charlottesville, and from year to year it changes. The N is very small, and so you can't use any single year. But 2 years ago, the differential was 11 times for Black women in Charlottesville, Virginia, than it was for white women, right? And about 4 times for Latino women. Now, usually when you see health disparities, if you control for education and socioeconomic status, those disparities generally disappear. Why I've chosen infant mortality is to emphasize the race problem. They don't with respect to infant mortality. Similarly, they don't with respect to maternal mortality, 3.5 times the differential on average in the United States. That's what I'm calling a race problem. I'm calling it a race problem because when I control for the confounding covariates that should make the differential disappear, they do not, and therefore the remaining variable that cannot be ignored is that there's something about being a member of a minority race, being a member of a population that experiences living as a minority in this country that affects that disparity, right? That's what I call evidence of a race problem with respect to medicine. Now, I could do it with death due to diabetes, I can do it with death due to heart disease, some cancers, not all, right? It's very complicated with respect to the delivery model, the location, and so forth. The report I have shown up here is probably familiar to most of you. The Institute of Medicine produced in 2003 a consensus report. 600 peer-reviewed studies that looked at disparities along the lines that I'm talking about, different delivery models, different care settings, and different diseases and injuries. And what they found consistently was a syllogism that sort of looked like this. The prevalence of disease is much higher in a minority population, fill in the blank, most often African Americans, right? However, the quality of care that these populations have access to is inferior, and therefore, the incidence of death due to this condition is higher, right? So that's just basically the formula for heart disease, all kinds of cancers, death due to diabetes, HIV, and you could, as I say, spend the rest of the day on that data alone, but describing it is not enough. So in answer to the first question, why should we worry about just medicine? We should worry about it because it is inhumane not to. We should worry about it because it's costly in terms of lives and dollars. We should worry about it because we can do something about it. Okay, so that's chapter 1. What is just medicine? What does it look like? I think it has 2 characteristics. All right? So what we're aiming for, and I want to just here parenthetically say, I did not name the part of the book that said I have a cure for inequality in health in America. That was the publisher, and I think that's a pretty bold claim. I walked it back, and I'm walking it back, but I will tell you what the characteristics of just medicine are. I think there are 2. One characteristic of just medicine is that it is equitable medicine. Equitable means that people get what they need, of course within the confines of a scarce resource model, right? What they need when they need it in order to have an equal opportunity to be healthy, right? An equal opportunity to be healthy. That's what equitable healthcare is, and that's one of the things that I would suggest if we spent time talking about what justice is. I look at the Rawlsian distributive justice model. If we talked about what healthcare justice is, what just medicine is, it's equitable healthcare. We look and endeavor to give everyone an equal opportunity to live a healthy life. The second thing that I think characterizes just medicine is that it takes the population and the preventive perspective of public health seriously. So I put the Broad Street pump up just to give you a visual for the notion that what we're looking for is medicine that looks not at retail solutions, but at wholesale solutions. Medicine that looks not at, to look at Kamara Jones's model, healthcare that's a safety net or asks to collect people from the bottom of a cliff after they have dropped off of it into emergency rooms at their most expensive intervention, right? But a healthcare system that looks way upstream and looks at preventing people from ever needing to go to the edge of the healthcare cliff and fall off into an ambulance and an emergency room because it is preventive. So those are the two characteristics of my definition of healthcare that is just. The only way we get there is intentionally. It won't just happen if we each work on our research, on our clinical care, on our conferences, on our papers, and even on our advocacy in isolation. And I put this picture up because it inspires me. I actually have it over my computer. Because on the one hand, the bigots came to Charlottesville, and on the other hand, we the adults, we the teachers, we the administrators, we the deans, all of those titles that I have in my name, I didn't go out like my students went out and fight intentionally against the bigotry. They did. They put their bodies in front of the statue, they got beat up, and they said, no, not on our watch, not on our ground, and they inspire me to remind me that the only way I'm going to get just medicine is if I do some of the things that I hear you are doing here today, some of the things that you're doing, taking surveys and testing models, some of the things that you're doing, making sure that the population of the workforce is diverse and looks like the patient population. It's intentional, and that's why that picture inspires me. So where is the injustice? Where is this thing called unjust medicine? This is chapter 3. It's the one I'm going to speed through at this point, because I have the sense that some of the information that I'm sharing here really is just level setting, but most of the people in the room know it, and I want to get to the part that is in chapter 4, the solutions part. So I'm going to go through some data. I started collecting it because of a line in this consensus report that we talked about, in which Brian Smedley's committee announced, we do know that there are disparities. We've documented them, and we've documented them, I'm going to say, ad nauseum, right? Because we know they're there, right? But we're not quite clear, we haven't elucidated, to quote the report, we're not quite clear what role implicit bias plays in the creation of those disparities. So my book is about what the role is that implicit bias plays in those disparities. And I'm going to confess right up front, another reason that I'm speeding through this is I don't know if any others in the audience have had this similar experience. I finished the book, and I closed it, and I said, now I know the book I really want to write, right? So I'm going to tell you what I wrote about very quickly, and then I'm going to tell you in the last chapter where I really want to stay, what I'm writing about now, and I want to test those theories out on you and have you inform my thinking. So I wanted to look at the mechanisms by which implicit bias might have an influence on healthcare and medicine. And as I say, put your seatbelt on now, because I'm going to go pretty fast. I'm going to start with a personal story so I don't have to do the science. It's always better to have an anecdote than it is to have data, right? So my story is about lift, right? I was a great runner in high school. I can't sprint from here to the end of the stage anymore, right? And so I've taken up long distance running. Everybody knows that somebody who used to sprint cannot really run a marathon, but I was training for a marathon. I was training for a marathon in Washington, D.C. when I was at the EPA, and so what you do is you basically give up the rest of your life, and you do these long runs, and you hire a lot of people to help you. So I had a chiropractor and a sort of a trainer person. He was like, you're crazy. Why are you doing this to your body? I was like, it's just sort of on my bucket list. And so on this particular Saturday morning, I had an 18-mile run. For a sprinter, that's like forever. That's going to take me into next week sometime, right? So I'm getting ready for my run. It's to start 6 minutes away. This is important. 6 minutes away from where I was living in Northeast Washington, D.C. So I'm living in Northeast Washington, D.C. I call the Lyft, and I go across the street to the Giant in order to get my banana and my fuel, you know, the things that, you know, I'm fussing with all of my meters and my GPS and all this stuff, trying to, you know, to get my head around, I'm gonna run for 18 miles, right? The Lyft guy comes at 6 in the morning, and I get in from the back side of his passenger side, right? So he doesn't see me until I'm sort of entering the car. That's important because he turns around and he looks at me and he goes, oh, you're going to Virginia, because as I said, I lived in Northwest Washington, D.C. The run started 6 minutes away at the Iwo Jima Memorial. Oh, you're going to Virginia. I said, yeah, I'm going to Virginia. I can't go to Virginia, I've been driving all night. I said, oh, you know, I'm a progressive lawyer. I understand power to the people. I'm gonna give you a really good tip. And I'm ignoring him at this point. And he turns around and he says to me, no, I'm not going to Virginia, get out of my car. Okay. So I'm from the South Bronx. And I'm like, girl, hold my earrings, right? Are you kidding? I jumped right straight to racism, right? I knew what was going on for sure, right? I've seen it, I can smell it, I know what's happening. And so I get a little arrogant and I said, oh, but you are going to the Iwo Jima Memorial. And I sort of, you know, did a few things with my neck. And he said, okay, locks the door and starts driving away. And I'm thinking, I really played this wrong. And now I'm petrified because I think I'm being kidnapped by a racist. This is not gonna go well. And so I give the door a bang and I said, let me out of your car right now. Sort of hysterically. And so now I'm angry and I'm hysterical and I'm all kinds of emotional things at once. I'm literally trembling. He let me out of his car only after he turned around and looked at me and said, well, what, do you want to go home with me? And now I don't even have words for the emotions at this point, right? Even telling the story, I can start shaking a little bit now, because I was really scared. I couldn't think of any way to retaliate against him, so I got out of the car. The first thing I thought was to key his car, but I thought, I'm going to jail if I do that. And so instead, I just walked around and I opened all 4 of his doors. I love that you laugh, because that's like the stupidest thing in the world. What is that gonna do? It's nothing. It's absolutely nothing. It was me trying to take ownership of a situation in which I was powerless, I felt devalued, I felt dehumanized, and all the things that have to do with racism came rushing into my physical body. And here's the real part of the story that I want you to hear. That was Saturday. I did my run. My husband and I were living in 2 different cities at that point, so he came to DC, and I was not a pleasant person all weekend. He was all too happy to say goodbye on Sunday night. He's like, okay, I'll see you next weekend. But I couldn't figure out what was wrong until Monday. I get in another Lyft cab. This time I have a black woman driver, and I tell her the story very briefly, and I say, is there anybody I can tell? Sure, she says, call the emergency number. So I call the emergency number, and the person who answers says in a very Southern drawl, Lyft emergency, what's your emergency, can I help you? I am flustered now. A, I don't really have an emergency, right? B, I'm not even sure it was racism. The guy didn't use the N-word. He didn't say, I don't like the way you look. Maybe he just didn't like women who were in short skirts running. I don't know. But I'm offended and I'm scared, and I got a Southerner on the phone. So I assume this is gonna get worse before it gets better. I start stammering out this story. I don't know if it's really, it happened 2 days ago, and I'm sort of stuttering over myself. I don't even get the story out, and here's what he says. Please hear this. He says, ma'am, that is an emergency. Nobody should have that happen to them. I will listen to you all day until we get this right. I immediately started weeping. I am a woman of a certain age. I think I hold it pretty together, but I didn't. At that moment, I started crying. Why? Because I had experienced what I thought was racism, and I held it in my body. Implicit bias hurts. Implicit bias changes your physiology. But hear me well. It works both ways, because what did I think of the guy who answered the phone? I didn't know who he was. I heard his accent, and I was sure this was going to get worse before it got better. And how wrong could I have been? How wrong could I have been? So I suggest to you that implicit bias is way more powerful than we've given it credit for. We know a lot about it, but we don't know how it affects people physiologically. We don't know how it is passed on from generation to generation. My mother grew up in the segregated South. She experienced Jim Crow, and she carried me when she could not drink out of water fountains, right? What did that have to do with my physiology and my ability to really muster my defenses against disease? It's unclear. So I want to tell you 15 really quick lessons about what I learned about the data that has to do with implicit bias, this thing that I'm going to reference in my life story as my life story example of implicit bias, and how it affects unjust medicine. So for here, let's roll really quickly. You know the model, it's environmental. You can have implicit biases about anything. Weight, religion, age, you can have it about anything. And it works automatically. It's triggered based on your social knowledge, right? Now I've got implicit biases against Lyft drivers that look like the guy who did what he did to me, right? And it might not even have been racism. I don't know. But I've got some implicit biases that are stored, that I trigger up, and it's because I'm human. It's not because I'm a racist. It's not because I'm a bigot. It's not because I'm a bad person. It's because I'm human. It's because I process information and I store it. It's because I get stereotype messages, you get stereotype messages, and they're in there, and they are automatically triggered. Now, don't hear me to say that you're off the hook because of that, because on the aggregate, implicit biases do the exact same thing as racism does, right? And perhaps even more insidiously. So, but what I want to say is that it's really important to recognize lesson number one, takeaway message number one, is that we've all got them, right? And the reason I want that to happen is so that we can de-demonize it, right? So that we don't falsely equate being the victim of implicit bias, or the holder of implicit biases, with being a bigot, right? Because bigotry doesn't do what implicit bias does. Implicit bias works automatically. It works unconsciously. It's preemptive. That's the thing that's really important. You could be an egalitarian in your preferences explicitly, but it will preempt your best judgment. So, takeaway message number two. See, I'm going to go really fast through these. We all have implicit biases. They're not the same as racism at the individual level, but in the aggregate, since we can measure them by this thing called the implicit association test. How many of you have taken it? Right? Oh, not enough for me to just speed through. Wow, okay. So the implicit association test is a test that was established it was first really popularized by Anthony Greenwald in 1993, I'm going to say, right? And it is basically a computer vignette kind of test, or a computer web-based test, which requires you to look and associate pictures and words quickly, right? The basic premise, it's a latency test. The basic premise is if you have a hard time, you're going to take longer making these associations than if you are easily able to make associations. So they show you a face like an Afro-American, phenotypically African-American face, and they show you a word, right? And some of the words are good and some of the words are bad, and you're asked to really quickly match them, right? It goes through 7 cycles, it's been validated, and this test basically times how long it takes you to make good associations and bad associations with phenotypically white and European faces, right? That's the basic premise. You get a score. The score ranges from -2 to +2, 0 being absolutely neutral. And what we see is that over time, because this test has been collecting data since about 1994, as I've said, right? Over time, in the aggregate, everybody who takes the test becomes a participant. Self-selected, no question. And there are problems with the test. If you're interested, there's a lot of data right now about the test's correlation with discriminatory decision-making and discriminatory conduct. We don't know exactly what it measures. It could just measure people feeling badly about racial stereotypes. But we do know this, that when you, unfortunately, the language, right, the syntax is, when you aggregate in America, the vast majority of Americans have anti-black, pro-white implicit biases. That's Black Americans, white Americans, Asian Americans have anti-Black, pro-white biases, and it has everything to do with your social knowledge. Very little to do with whether you really are or are not a bigot. But that's what the numbers tell us about a self-selected population, which is likely understating the reality in the United States, because who goes to the website and takes the picture? I don't think the guy that organized the march in Charlottesville is going to this website, right? So we're probably understating the case, right? What we do know, notwithstanding the individual level problems and limitations of the implicit association test, is that when we aggregate implicit bias numbers at the community level, they correlate very closely to other measures of racism, right? So they may not be accurate at the individual level, but they correlate an example, they correlate very closely to racism measured by the number of online Google searches for the N-word, right? When you aggregate online Google searches for racial epithets like the N-word, and you get rid of the ones that have to do with those crazy songs, right? You have an objective measure of the interest in racial epithets on a geographic level, right? And so community level implicit association scores are very, very close to that same geographical concentration of racial discrimination. Now, another talk I give correlates those community levels of racism to disease and the incident of injury, right? High-level correlation, racism hurts. So aggregating implicit association measures reveal a community-level implicit bias that operates the same as racism, and that's why you don't get a buy just because everybody has it, right? Because it's harmful. Now, look at the evidence in healthcare, all right? I think most of you have heard of the Kevin Schulman study in 1999. That study was the first to correlate race, gender, and treatment decisions, right? But no mechanism. Right? So that study basically took 8 actresses and actors who were identical except for the fact that they were either male-female or black and white. Dressed them the same, they read a vignette that was a history and physical, told the participants what the problem was, and then they had to make a decision about the treatment of choice. And the good thing about doing heart disease as the disease is that there was a treatment of choice. And if I'm remembering correctly, and you'll check me if I'm wrong, Kevin Schulman's study, the treatment of choice would have been thrombolysis, and what he found was a high correlation between race, gender, and the decision to treat with the treatment of choice, right? That is sort of the entree. Maelstrom, lots of New England Journal of Medicine, debate, but what we didn't know was the mechanism. Alexander Green was the first one to tell us what the mechanism was, or to suggest that implicit bias could be the mechanism. Again, I think I can leave these slides so that I don't use too much of the time just going through the studies, but I'll stop and pause here at one, and then one more, and then the others I'll just tell you that they exist. So Alexander Green's study is really important because it's the first one that says what we're going to do before we ask the vignettes responses for the treatment of choice. So we're going to take 2 tests, one for explicit bias and one for implicit bias, right? We're going to use that implicit bias test. I'm doing this with my fingers because that's the video-based test where you do the latency response to the pictures and the words, right? And then we're going to give you a survey that basically says, are you a racist, right? And the surveys for 287 participants, if I'm remembering the number correctly, people said, no, I'm not a racist. I know the best answer. And in fact, in the United States, racism is pretty much out of the vote. Contrary to what you might think because of the political discussion right now, most people in the United States abhor racism, right? And so the explicit baseline was no, I'm not a racist. The implicit baseline was a range, right? So you had a continuous variable. And then you could correlate that with recommendations for treatment, right? And what we found was that the treatment decisions correlated to the level of implicit bias by race. So there was a higher probability of a physician who had a lower implicit bias number giving the treatment of choice to blacks as well as whites, and a lower probability, or the probability declined, of giving the treatment of choice to blacks as well as whites as their implicit bias numbers increased, right? So said another way, the more biased you were, the less likely you would give treatment of choice to blacks as well as whites. This is groundbreaking, right? If you can replicate this, then what we're saying now is that implicit bias has a direct impact on the quality of care that people will get by race, right? That's what we're saying in this data, right? And so again, a lot of discussion. Actually, if you look at the study and the responses to it, Alexander Green had to walk some things back because he mixed up risk and odds ratios and all kinds of good stuff. But at the end of the day, he said, I'll tell you what, I don't think the difference is statistically insignificant or is socially one that we can ignore. Unconscious or implicit race bias among physicians is dissociated from the explicit bias and correlated to treatment decisions. That was one of the most important studies. Now, the others are like unto them, right? The reason I want to pause and include Irene Blair's study, she's my former colleague down at the University of Colorado, or over at the University of Colorado at this point, is because she actually did not replicate that with respect to primary care physicians treating hypertension. So I want to complicate the discussion and not say that every physician is implicitly biased and is always acting out of that bias in making treatment decisions. No, that's not what I'm saying, but I am saying that there's a correlation that's non-trivial, right? And that we have to investigate why Irene's study of the same question, does implicit bias, because she did the same two tests, and looked at then hypertension outcomes and treatment decisions, intensification of medication, and other treatment decisions, and she did not replicate those findings that Alexander Green had. So what we have to ask ourselves is, why are some subsequent studies replicating and some not? Do we sort of say, oh, good, phew. Aberrational study in the Green instance. No, it wasn't aberrational. But what we do know about Irene's study is that probably it had a lot to do with the fact that most of the physicians in her study, in fact, all of the physicians in her study, were primary care physicians or cardiologists, right? So one of the things we have to worry about or think about and interrogate is whether the practice field makes a difference. And we think that it does. Why? Because pediatricians, primary care physicians, and probably internists and cardiologists develop long-term relationships with their patients and see them more as individuals than they do. My husband's a cardiac surgeon, right? He loves to cut, right? A chance to cure is a chance to cut, right? And so his relational experiences, oh, I hope he doesn't listen to this. I'm making him look really bad, right? His relational experiences are quite different. The other thing that was really interesting about Irene Blair's study is that she did it in safety net hospitals. Well, one of the hospitals was a really important safety net hospital in Denver, and the other was Kaiser, right? So we think that there are things that we have to learn. So it's complicated. It's not easy. But we can take away this message. There is a correlation that we have to interrogate further between implicit bias and treatment decisions. That's important, right? There's also a correlation according to several studies. My favorite, and this is the last one I'm going to pause at, I think. Kelly Hoffman did a study at the University of Virginia of medical students' perceptions of people based on race. And this was a group of medical students, and her inquiry was about the perceptions that people have about blacks and whites' relative experience with pain, right? So how many people already know this study, right? A lot of people know this study, right? So medical students in their third year of the University of Virginia were given a series of statements, many of them untrue, about black people and how they experience pain. Untrue to the extent that they were crazy, right? Crazy in retrospect, like black people experience less pain than white people because their skin is thicker, right? Or black people experience less pain than white people because their bones are thicker, or their blood coagulates at a different level. Things that are just patently untrue. But the number of students that A, affirmed an untrue statement, and then B, exhibited a correlation between their willingness to treat pain and that untrue statement differently for Black versus white patients, was over 50%, right? So here we don't have a latency test. We have biases that are born of simply untrue stereotypes, right? And they affect treatment decisions. So we have a race problem, and we've got to pay attention to the extent to which it affects physicians, right? Michelle Van Ryan talks about perceptions in a different way. She talks about how many physicians are, before they enter the encounter, the clinical encounter, already thinking that there is a empirically unsubstantiated difference between the amount of drug use there is by race, the amount of compliance, the warmth of people's compliance, resource levels not estimated at an individual level, right? And these are perception differences that are carried into, Michelle Van Ryan is at the University of Minnesota, and she does this beautifully by recording encounters and then doing questionnaires after, right? So another takeaway is that perceptions, like a preconceived notion about pain differences, probably are another mechanism by which implicit biases affect health outcomes. Like Michelle Van Ryan's study, probably implicit bias has an association with outcomes as well. Lisa Cooper is a physician at the Johns Hopkins Institute, and she looks at communication and implicit bias, right? So she'll videotape a clinical encounter, and then she'll code that video and audio tape, and she'll look at the differences of of communication between a patient and a physician, and then correlate it with implicit association tests, right? So this is a lot of research that I'm throwing at you just to let you know that we have a lot of data that suggests implicit bias does affect health outcomes at the individual clinical level, right? And what Lisa Cooper finds is that she can see differences in the level of eye contact, the length of eye gaze, body language, right? She can see differences, for example, in the verbal dominance, how much information is coming through, right? And she can see that on the physician side. So the takeaway is that it does likely have a correlation or an impact on communication between physicians, but let me show you, this is what my interviews showed. It has an influence, implicit bias does, on the patient as well, right? So I'm going to use you, Liz, as my example. You're my physician, I'm your patient. I walk in the room with social knowledge about you before I've met you. I've got a preconceived notion about you, right? And you have a preconceived notion about me. Our perceptions start getting affirmed in our conversation. I look at you and I say, she's folding her arms. I don't really trust her. I knew it. And she looks at me and she says, I know she's not very cooperative. That's how those Black women are. And so she sits a little bit further and she wiggles in her seat, and I said, you know why she's wiggling? And I've got an attitude and she's got an attitude, and we're off to the races, right? We are feeding on one another's distrust, on one another's stereotypes, and I'm suggesting that that has something to do with patient satisfaction. It has something to do with adherence. When I interviewed Black, especially middle-class patients, if they decided you were a racist as a physician, they not only didn't go back themselves, but they called all their friends and said, don't go, right? Because the social network, it's very powerful, right? So we had one instance where this, and I'm not going to tell you the city, it's a Midwestern city. This guy had a practice, and he was the sort of physician of choice in this small Midwestern city for Black patients one day, and the next day he didn't have a single one, right? Because people just say, and so what does that mean about outcomes? It means continuity of care is broken, right? And so this is another mechanism. I'm going through a lot of data, but it's a lot of mechanisms that we suggest that implicit bias, this is too much fun, I can't do it now, but if you think about implicit and explicit bias, you have a 2x2 matrix, and you can have a combination of high and low of each of these, right? Lewis Penner at Wayne State University looks at the combination of high implicit bias, low explicit bias, right? That's called an aversive racism in his lexicon. It is the one, he did 183 patients' responses. It is the one combination that patients of color hate the most, right? They'd rather take a frank bigot, I know you don't like me, but you're not gonna kill me, right? I don't think. And the combination of low explicit, high implicit bias, what he calls an aversive racism, is the one that patients of color will not go back to. They express the lowest amount of satisfaction. So, takeaway lesson number 7 is that bias, I'm just going through a series of mechanisms by which the data suggests that implicit bias does influence health outcomes and health disparities, right? Because that was the question in the Institute of Medicine. We know that bias has some relation, but we can't elucidate what the relation is. Here's another mechanism: patient satisfaction and adherence. I'm not going back if I think you're in aversive racism. The book has 6 other mechanisms, and they account for the 84,000 deaths that Tom Levis and others estimate happen a year needlessly, not all due to implicit bias, right? Not all due to implicit bias. But I'm suggesting that implicit bias is non-trivial in its influence, and $1.24 trillion is a very old number. David Satcher came up with it. I understand they're coming up with a better number every 3 years, that it costs us in increased medical costs, lost productivity, et cetera, to have those 84,000 deaths. We need, lesson number 8, we need to see that implicit race and ethnic bias are correlated with costly discrimination. Right? It's not just discrimination that costs the victim, it costs the perpetrator, it costs the system, right? And this cost is something that we should pay attention to. In a medical center like MD Anderson, the bias that I've been talking to can be replicated not just between patient and provider, it can be replicated between patient and nurses, patient and physician extenders. It can be replicated between student and professor, administrator and student, and every relationship can replicate these, right? So, oh my God, we have such a big problem. What are we going to do to combat it? Takeaway message number 9, there is good news. Probably, right? And that is that there's also 25 years of data that tells us that implicit bias is malleable. You can do something about it. Now, I'm sorry to say, but that is music to my lawyer ears. Because as soon as I know you can do something about it, I can hold you legally accountable for doing something about it. And so fast forward to the end of the book, what is my solution? I have a new way to sue you, right? So is that a good solution? No, it's not really a good solution at all. If you want to talk about it in the Q&A, I'm part of a team that has convinced one of our legislators in the Senate to come up with a bill that would change anti-discrimination law that would actually include unconscious and unintentional bias as part of a legally actionable claim. Even if I do that and I bring a suit, I am not going to stop implicit bias in medicine. It really does depend on you guys, right? So I know that my legal tools are blunt instruments, but I'm going to use them anyway, right? So that I can change the social norms. But malleability is what I want to talk about really quickly. Remember that Alexander Green study that we saw there was an inverse correlation between the likelihood of giving the treatment of choice to black and white patients equally and your implicit bias numbers? Here's what we know. There were 67 physicians who were told expressly that the study was actually about race, racism, and healthcare, right? I don't know if they used racism as the word. Race, racial discrimination, and healthcare. Those 67 physicians exhibited the reverse pattern. Right? You can do something about that. Now, we haven't been able to replicate this, right? But we have been able to see that some of the interventions, some are quackery, quite frankly, but some of the interventions that we have now to de-bias physicians and police officers and all kinds of people at this point actually work for a short period of time. Like, we can change your implicit bias numbers, right? Now, again, if you want to talk about the problems with the implicit bias measures, we can do that later. You can do individual things. You can do organizational things so that you structure decision-making so that it is less discretionary, because that's where implicit bias flourishes. It flourishes where there's high discretion, high power differentials, right? Low information, low relations. We can do something to change those. But here's where I really want to spend the rest of my time. I don't know how much I have left, but this is the part that I'm really interested in. How am I doing? Huh? Uh-oh. I don't know what to do about this. Okay, so what I want to talk about is systems, right? So the whole book is about individuals. Thank you so much. The whole book is about individual relationships and structuring organizations to change individual relations. What I want to talk about is structures and systems, right? Because I, after all, do have to every night go to sleep with a doctor who says, oh, you got another thing you want to sue me for, right? And seriously, it's not just because of that, it's because, in fact, the evidence that we have of implicit bias's real injury is at the aggregate level, at structures, at systems, at institutions, right? And so let me talk a little bit about, and here I'm in the theoretical realm. This is the book I'm writing now. And if you want to disagree with me about the parts that I've already said, I got data out the wazoo probably to answer your disagreements, right? Here I'm in, it's almost 7 now. Okay, Okay, so I'm going to leave 15 minutes for discussion by going through this part much more quickly than I intended to. And I'll use this slide. How many of you remember The Flight? That was the basis of Sully, the movie. Okay, so really quickly, I want to ask you, this flight lands on the Hudson River after it hits a gaggle of geese, and all 155 souls on board are outside the plane. Can you see that they divide into 2 groups? Right? Can you see that they divide into 2 groups? Somebody shout out what the difference between group 1 and group 2 is. First class and not first class, right? So what's the difference between first class? They pay more, yes, and therefore they get a raft, right? When they end up in January in the Hudson River, they have a raft, they have a little box with rations, they have little flares, they have jackets, right? What are their life chances of getting plucked out of the river alive in January? Way better than the other people on the wing who, that plane went down, right? And they're all crowded on the wing. Thank God I can use this picture because all 155 souls got saved, right? Which is all I'm saying about the healthcare system. I'm not saying everybody has to have first class, but everybody ought to have a chance to be saved. That's equity, right? And what I want you to see in this slide is that place matters. I want to ask you to concern yourself much more with the structural differences in my life chances versus your life chances if I am not in first class on this plane, because that's where implicit bias does the population level damage, right? So really quickly, some ideas that I have, right? Everybody's seen this slide, the 40% social determinants of health is where we ought to be concentrating. My book concentrates mainly on the 10% clinical care, right? That's why I closed it out. I was like, oh, really good, you did not much difference, right? If I really want to make a difference, I need to be in that blue quadrant, social and economic factors, and I would argue, if we had more time, that that blue quadrant that talks about health behaviors is also significantly influenced by social and economic factors as well, right? So that's where the money is. That's where the payoff is. Residential segregation, that's what I'm writing about right now. Let me tell you about residential segregation. It used to look like this, and this is what our law is intended to address, but residential segregation doesn't look like this anymore. It doesn't even look like this anymore. This is redlining in the city of Houston, right? And you know what redlining is? It's, I'll lend to you if you live in a neighborhood that doesn't have any Negroes or criminals. That's what it said in 1930, right? Negroes and criminals equated, right? But now it looks like this. The map that was redlined in Houston in 1930, we were talking about this, oddly flips. This is a racial concentration of the percentage of white population in Houston today. The fact that there is enough concentration to see that in the inner city it is almost white, right? And I mean the color, not the race, right? And around the suburbs it is deep, deep purple, right? That's residential segregation. And it persists today, and we know there's a very high correlation between low income and residential segregation, and therefore, Michael Marmot told us this with the Whitehall studies in 1991, that there is an almost perfectly linear relationship between socioeconomic status and health outcomes. That's a population problem. And because they correlate so closely with residential segregation and race, that's the kind of population discrimination that I think we ought to be aiming at if we're really interested in making a dent in health outcomes. This is a public housing map for for Houston, and you have, I think this is amazing, you actually have a white public housing neighborhood. Memorial Drive, I mean, it's amazing. You have an all-white projects, right? Which is what we used to call it in the South Bronx. What happens when there's residential segregation? Substandard conditions happen, right? And the concentration around the country is among Black and Latino patients primarily. This is a neighborhood in Houston, substandard living conditions. This is an open sewer. This is like open sewer, right? Or open water drain at least, right? It's a sewer. Right? That's in Houston today, right? So what's the big surprise about health disparities in neighborhoods that have this kind of structural neighborhood defects? You can do all the exquisite healthcare you want. You're fighting and competing with structural disparities that are going to kill you in terms of the effectiveness of getting your outcomes improved on a population level, right? The example I always use is asthma. If you have a kid with asthma, you send them home with albuterol, and you send them to a moldy apartment that's not meeting building code, I don't care how good your albuterol is. It can't fight against mold, pest infestation, and lead. Can't do a thing about it, right? So your practice of medicine is incomplete until you consider these kinds of outcomes. And right now there's a suit, because that's all we can think of doing as lawyers. It's been filed in the DC District Court against the Housing and Urban Development, addressing substandard housing and discrimination in Houston. I hope I live long enough to see this suit complete and actually do something about it. I implore you to think about doing something before this suit does a thing, right? Affordability, concentration of poverty, highly correlated with poor health. If you don't address that, you're not going to do a thing about the part of that Tarlov graph that says social conditions are more important than clinical conditions. Housing is an important determinant of health. This is what food discrimination used to look like, and we have laws against this, right? You can't do this anymore. When people sit down at a counter and they want a hamburger, and you tell them they can't have it and throw ketchup on it, I got rules for you. I don't have anything for the food insecurity at the legal level that persists in Houston today. I need you to consider this part of your health obligation, right? I don't have answers. I'm just suggesting that the questions need to be larger. They need to include structural discrimination, not just the discrimination I wrote in the book, because food discrimination and implicit biases with respect to food have a correlation to poor health outcomes. This is the discrimination that we see in education in the law, right? I know what to do about this. I know what to do about the fact that if you gather around a Black student trying to enter school, a Latino student trying to get to school, and you tell them they can't come in because of their race, I got the law for you, right? And I can pretty efficiently do something about that. I can't do a thing about it when it looks like this, as it does in Houston today, right? I can't do a thing about that legally. But I'm suggesting to you that you enlarge your concern with respect to health and health outcomes to include this problem, because it does affect health outcomes of the patients that you're trying to teach, that you're trying to treat, excuse me. Lastly, not only is educational discrimination and bias a correlative to poor health outcomes, but criminal justice bias is also. I can now do something about this in my legal system, but I am from Colorado, and so I know this data. I know this data that on the one hand, Blacks and whites use marijuana at about the same rate. That's why the use lines, dark blue and light blue, are pretty much the same. However, I know that they are arrested at vastly different rates for violations. And who's getting killed here? It's the kids. Because in Colorado, where marijuana is now legal, it's only underage use that's getting prosecuted. And the disparity is being prosecuted disparately by race, right? And when you do that, you change the health outcomes. Now, I'm not telling you that this is Texas numbers, right? I'm not telling you that you have the responsibility for fixing the criminal justice system where you're not delivering good health care. That's not what I'm asking you to do. I'm asking you to recognize that disparities in criminal justice, in housing and education, and food security, all of those affect your patient health outcomes. All of those, we have to think about new health models that incorporate and deliver care in a way that accounts for and addresses this. I was in Flint, Michigan I wasn't in Flint, Michigan. I was in the office of the senator for Michigan when Dr. Mona Hanna-Attish brought to our attention the elevated blood levels that ended up causing us to identify a state of emergency in Michigan called the lead water contamination crisis, right? If you map the other 20 cities in the United States of America that have lead pipes as corroded with lead as Michigan, you will find 20 cities, and similar to Michigan, predominantly black, predominantly poor neighborhoods, right? What allows that to happen? Implicit bias. I have this picture because I think Governor Snyder is not a bad man. I think he's a good man. And when he said, I don't think this has anything to do with race, I actually think he believes what he was saying. But we have to stop thinking in terms of the binary, are you a racist or not a racist? He is not a racist. He's not a bad man. He's not a member of the wrong party. But we haven't had an honest conversation about what implicit bias on a structural level does. Environmental hazards are another one. And here's something about life expectancy in Harris County. All right, so how do you fix it? How do you achieve just medicine? I know I'm not supposed to use the screening word, but you have to figure out how to identify social conditions that are affecting outcomes. That's intervention number one. In your histories and physicals, in the way that you gather information, I think you have the answer, I don't, but I think it has to become a part of the medical conversation. That's intervention number one. Number two, healthcare has to be collaborative. No longer are you able to solve the complex population problems on a preventative basis that will give equal access to the opportunity to be healthy by yourself. And because I'm not asking healthcare delivery to become the answer to poverty or the answer to racism, you have to find partners, right? And you have to find ways to collaborate that don't freight on you a new standard of care, but that recognize you are not going to beat health disparities alone, right? So these are two possible hub models. One where healthcare is at the center. It's not my favorite. My favorite is where public health is at the center. We can talk more about why. But I think there are ways in which collaboration and partners and integration, intervention number three, integration so that in the healthcare delivery model, we are not just talking about delivering albuterol to that kid, we're also delivering a social worker and connecting them not to a referred lawyer, but to a lawyer who's part of the healthcare team. So that the lawyer can work not just on that kid's apartment, but all the apartments in the complex. It works. I don't have to take anybody to court. Just write a letter to your landlord, guess what? I noticed that there are a lot of apartments that are not up to code, and voila, right? Access to justice really is access to health. And lastly, if you will research the connection between race bias and health, what you will find is what many researchers, the literature's nascent, has found, that it affects the health of both target populations and perpetrator populations. And that might help you get some traction down at the Texas legislature when you try to address it. So those are some studies. I'd like to ask you, the last intervention is that some of y'all need to come with me to Capitol Hill. I'm sorry. I know it's not what you went to school for, but this will be my closing story. My job, when I was at Senator Stabenow's office, because I'm basically useless for a year, right? So my job is to take constituent calls. When they came from doctors, we listened. When they came from scientists, we listened. When they came from public health specialists, we listened. Why? Because health quantifies injustice. And it gives us an evidence base to actually make policy. And so I'm asking not all of you, but some of you to take your scientific knowledge and do what you're doing with it in policy even more. That's lesson number 15. I did 15. My conclusion is that we're all accountable. This is a stand of aspen trees. Colorado is the state I just left. They look like individual trees, but they're not underground. They are all connected, one organism. And I think if anybody's going to convince us in these United States that we are one connected organism, it is the healthcare profession. And so I'm asking for your help, thinking this through more clearly. What I've not gotten right, please help me. But that statement on the top of the building, connecting the world of research, ideas, and knowledge to the world of action, honestly, I think it depends most on you, more as a professional group of scientists than anybody else in the United States. So thanks for giving me the time. Two questions. I've got time for two questions, yeah.
A few.
I really went over.
So the floor is open. If you'd like to go to the microphone, please.
They're stunned.
Thank you for your amazing presentation. I'm currently reading the book, The Warmth of Other Suns. Well, first of all, my name is Joyce. I'm a Master of Global Affairs candidate here for 2019. So, and before I read this book, I was thinking about the migratory patterns in the United States during Reconstruction and how a great number of African Americans moved from the South due north, or, you know, other cities that didn't have, or states that didn't have Jim Crow. So the paper that I was writing before having written this book is, rather, a paper is the pattern of their now migrating back to the South. And as you were speaking, I was just thinking, I wonder how their health was affected, not just by Jim Crow, but even the movements and still the things that they encountered in the cities there. So I wonder if you have any data or research that could help me in writing the paper. Thank you.
So one of the things I love about being an academician is that all these questions are opportunities to create new knowledge. I'm not aware of a literature about the health connection between the Black migration or African American migration, south, north, and then return. There are data, and there is a literature about displacement and health impacts, especially mental health impacts of displacement. They're mostly connected now, current literature, with what people call gentrification, which is a terrible word because it suggests that the people that got displaced weren't gentry, but anyway, we can use it to understand. So that literature might be an entrance. I can't imagine that there is not a literature about migration and health, but that's where I would start. The other thing that does occur to me is probably migratory patterns in countries other than the United States. There's a woman named Sanyo Mojola, M-O-J-O-L-A, if I'm remembering correctly, Sanyo Mojola. And she writes about AIDS and migratory patterns among women in Kenya, right? So that might also get you in the literature because she talks about how that movement really does a nice job of showing us the vectors of the travel of HIV infection. But that's as close as I can come.
Hi, my name is Justin Onwenu. I'm a recent Rice grad, interested in healthcare and law as well. I'm curious if you've looked into, I know the United States has a particularly unique history with race, but I'm curious if you've looked into other countries and I guess along those lines in the United States, if you've broken things down based on geography. So Maryland having a large Black middle class, if you found similar health disparities in other regions of the country as well.
Yeah, I haven't, but there is a literature that starts to sort out, for example, the lack of homogeneity among African Americans and people of African descent here in the United States, right? So some of the things that we see with maternal mortality is that it makes a difference if you are a Black immigrant or you are Black American, right? Some of the things that we can see in socioeconomic differences are actually quite disturbing, right? And that is that we can't get rid of disparities entirely when we control for socioeconomic status for Blacks who are middle class in Baltimore, as opposed to Blacks who are living in, Southeast DC. And so that's where the weathering hypothesis comes in, that has something to do with being Black or being an immigrant in the United States and how it affects your allostatic load. But again, the research is nascent, and I'm in a research institution, and I'm saying those are important questions, right? Because otherwise we're going to paint solutions with too broad a brush. We're going to spend a lot of money doing things that don't work. But yes, there is, especially with respect to breaking apart the Black diaspora and also looking at the difference in Latino populations, right? To be Cuban is not to be Dominican, is not to be Mexican, is not to be Puerto Rican, and so forth, right? And so some of that literature is already emerging, but we need lots more.
Hi, I'm Victor Prieto, a pathologist from MD Anderson. And first of all, thank you very much for coming and giving us this fantastic lecture. I found very encouraging the slide that you showed that by teaching people, you can reduce the implicit bias. So I think that definitely supports the efforts that some of our institutions, and many of our institutions, are currently taking for actually to do exactly that, to reduce our implicit bias.
Yeah, I agree. I hope that your institution will do one other thing that we really need. I'm very encouraged by the number of institutions that are doing debiasing training. We need evaluation of that debiasing training. What difference is it actually making, right? And the emerging literature shows us that some things make a difference and some things don't. So we don't want to be blind to the impact, the effectiveness, and we want to evaluate those interventions as well. It's hard because sometimes you spend a lot of money and you do a lot of work and you find out, that didn't work so well. But some of the things that we're finding out that work, we can proliferate and do a better job with them. So I'm encouraged as well.
My name is Hillary Fairbrother, and I am an emergency physician in the Texas Medical Center, and I have the good privilege and honor to spend at least half of my time teaching first and second year medical students. And one of the things that I work on is teaching about implicit bias, and you led right into it. So I spend an awful lot of time talking to them and teaching them, and we did an amazing poverty simulation yesterday, today, and tomorrow, and it's so amazing and wonderful, but we don't measure it. And I'm a scientist, so what's the next? I know implicit bias is malleable, and I've read that research, but how do you propose to measure the interventions that we're all trying to do? I just don't know if what I'm doing is effective.
Yeah. We thought we could do pre and post tests and look at your implicit bias numbers before and after, but we find out that those numbers are also malleable, right? I can figure out a way. And I will tell you where I end up. I grew up in the segregated North, right? So at my age, for the first, I'd say, 10 years of my life, the only people I trusted were Black people, right? They were my teachers, they were my deacons at my church. And so I fall into that very small category that has strong anti-white, pro-Black biases, right? And for a long time I didn't tell people that because it was like embarrassing. And then I said, well, if I'm asking people to disassociate this with racism, then I have to be willing to say, I can disassociate it as well. It's not racism. So now that I can measure my bias, would it make a difference if you could move me up that implicit bias and implicit association scale? I don't think it would. I really don't think that's the outcome we should be measuring, right? I think a couple of things we should be measuring are aggregate decision making, right? How many people are being referred to for the treatment of choice in whatever field it is, right? How many people are we admitting into mental health treatment as opposed to referring to jail, for example? What are some of the kinds of, again, population level outcomes that we think are associated with implicit bias? Does changing the bias actually change those as well? It's going to take a while to figure out what the measures are. I would argue not to measure individual level biases. I think that also advises or counsels the wrong kinds of solutions and accountability. There are a few studies that suggest when you point out people's biases, they balkanize, right? So I think it's wrong to say what we want to see is if we've moved your individual biases along a metric. I think what we'd rather see is whether systems actually have a health population or systemic outcome. That'd be my suggestion.
Hi, my name is Megan Dupuy. I'm a HEMONC fellow at MD Anderson, but we have the, I think, good fortune of not only seeing patients at Anderson, but we also go to the county hospital. And I was hoping you could comment on unjust medicine and the intersectionality with implicit bias and access to health care in terms of health insurance. I've seen a lot of patients who could be cured for their leukemia if only we could get them to transplant, but we can't because they can't afford it or they're undocumented. And for us, this is a real pain point because you're looking at young patients who should have the access that we can see down the street at Anderson for potential cure. And at the county hospital, we service patients who are predominantly minority.
Anything I could say that would improve upon what you said, right? Access seems to be the lowest possible hanging fruit. Getting people access to health care in this country is getting them access to insurance. The data that tells us that life expectancies narrow after age 62 is, in my opinion, all the data we need to say when people get access to health care, disparities narrow. Why? Because everybody can get treatment. That's so easy. So go out there and make it happen. Thank you.